Assalamu alaikum warahmatullahi wabarakatuh. Welcome back to the channel of Stand Medical Notes. So let us continue the topic of diabetic ketoacidosis. So what should be the investigations? What should be the diagnostic approach? Investigations include capillary blood glucose, serum or urinary ketones, metabolic panel which includes electrolytes, bun, creatinine and glucose, arterial or venous blood gases. So these are the cornerstone investigations of DKA. This is one. The second one is the infectious workup, which includes CBC, urine analysis, chest X-ray, cultures as indicated. This is the second one, to know any infection. Okay. And now diagnostic criteria according to ADA 2025 updates. So you will see pH and anion gap and serum bicarbonate level, serum or urinary ketone level, serum glucose level. Okay, 5 things. So pH less than 7.3, anion gap of more than 10, okay, milliequivalents per liter or millimole per liter, bicarbonate less than 18, pH less than 7.3, bicarbonate less than 18, quantitative blood beta hydroxybutyrate more than 3 millimole per liter is vastly superior to urine nitroprositis, which only detect acetoacetic acid and can yield fast negatives, as beta hydroxybutyrate is the predominant keto acid in severe diabetic ketoacidosis. Okay. Serum glucose more than 250 milligram per deciliter. Okay. So these are the 5 criteria. pH less than 7.3, anion gap of more than 10, bicarbonate level of less than 18, serum beta hydroxybutyrate level more than 3 millimole per liter, and serum glucose level of more than 250 levels. Now, due to the one clinical logic, due to the osmotic effect of severe hyperglycemia, drawing intracellular free fluid into the extracellular space, the measured serum sodium is artificially lowered. So, pseudo hyponatremia. The corrected sodium must be calculated to assess the true free water deficit and guide subsequent fluid therapy. So because of the osmotic effect of severe hyperglycemia, which draws intracellular free water into the extracellular space, so that will cause dilutional hyponatremia or pseudo hyponatremia. Because of dilutional hyponatremia, corrected sodium should be calculated in patients with DKA. How do you calculate? Measured sodium plus 1.6 into glucose levels in milligram per deciliter minus 100 divided by 100. For example, if glucose is 250 milligram per deciliter and sodium is suppose 132, then it is 132 plus 1.6, 250 minus 100 divided by 100, then it is 132 plus 1.6, that is 150 into 150 divided by 100. So that is equal to I will take this here, 132 plus 1.6 into 1.5, that is equal to 132 plus 50 is the 2.25. So the corrected sodium is actually 134.25. So that's how we calculate the corrected sodium. Okay. So measured sodium plus 1.6 under the bracket, glucose in milligram per deciliter minus 100 divided by 100. This is the formula. Sodium should be in the levels of milliequivalent per liter. Glucose in milligram per deciliter result in milliequivalent per liter. Okay. Now one key point here. Diagnosis of DKA requires all criteria to be met. Okay. Quantitative beta hydroxybutyrate measurement is the gold standard for detecting and monitoring ketosis. Okay. So all criteria should be met to say it as DKA. All 5 things: pH, anion gap, bicarbonate, glucose levels, and quantitative measurement of beta hydroxybutyrate or urinary ketones also you can take. But the gold standard is quantitative measurement. Okay. That's about the diagnostic criteria. What should be the management strategy then? So management strategy, the management of DKA relies on simultaneous aggressive intervention across 4 pillars. 1, volume; number 2, potassium; number 3, insulin; number 4, underlying cause. So in this manner you will correct. This is the strategy: volume, potassium, insulin, and cause. Continuous clinical and laboratory monitoring is required, often necessitating ICU admission. So this management should be done concurrently with monitoring. So coming to first, volume expansion. The goal is to restore the intravascular volume, ensure kidney perfusion, and lower the counter-regulatory hormones. How do you do that? Give 1 to 1.5 liter of 0.9% normal saline in the first hour. Subsequent fluids depend on the corrected sodium. For example, after 1 hour, if the sodium level is normal or high, meaning either it is equal to 135 or more than 135, then we should give 0.45% NS at a rate of 250 to 500 milliliter per hour. 250 to 500 ml per hour. Now, if the corrected sodium is low, meaning less than 135 milliequivalent per liter, then continue 0.9% NS at a rate of 250 to 500 ml per hour. Okay, so in the first hour we are giving 1 to 1.5 liter of 0.9% NS in 1 hour. 1 hour you are giving. Then after 1 hour, the fluid, which type of fluid, either we should go 0.45 or 0.9%, depends upon the corrected sodium level. If the corrected sodium is equal to 135 or more than 135, then we will give 0.45% NS at a rate of 250 to 500 ml per hour. And if the corrected sodium is less than 135 milliequivalent per liter, then we will give 0.9% NS 250 to 500 ml per hour. Okay. Now one thing is, when plasma glucose falls to less than 250, you can take 250 milligram per deciliter. Switch IV fluids to 5 to 10% of dextrose. Example, D5 to 0.5% NS. Okay, D5 0.5% NS, meaning dextrose 5 and 0.5% NS. Okay, 5% to 10% dextrose. So this prevents hypoglycemia and allows insulin infusion to continue until DKA resolves. Why we are doing this thing? Because even though the blood glucose level is falling, but still the acidosis will not resolve. So insulin is required for complete resolution of acidosis. So if you give continuous insulin and the blood glucose is falling below 200 level, then patient may land up with hypoglycemia. That's why we are giving 5 to 10% of dextrose, so that blood glucose should not fall further and acidosis gets resolved with the help of insulin. So that is the funda behind giving this 5 to 10% of dextrose when the blood glucose level reaches 250 or 200 levels. Okay, so volume we have done. Then second is potassium repletion. Goal is to replace total potassium deficit safely and prevent life-threatening arrhythmias before starting insulin. So what we should do before starting insulin, we should always check serum potassium levels. Now, if the serum potassium is less than 3.3 milliequivalent, do not start insulin. Give potassium 40 milliequivalent per hour until potassium is more than 3.3 milliequivalent per hour. And one practical point is, for 1 pint of NS, 1 pint meaning 500 ml of NS, you can add maximum of 20 milliequivalents of potassium, IV potassium. If you are giving this potassium through the peripheral venous route. But if you are giving to central route, then you can give 40 milliequivalents. Okay, so this one important point we should remember. So if you are giving peripherally, so 20 milliequivalents at a in 1 pint ns we can give, but if we are giving central line, then we can give 40 milliequivalents also. Up to 80 milliequivalents you can give, okay, 40 to 80 centrally. Now if the measured potassium level is 3.3 to 5 milliequivalents per liter, then start insulin, but along with starting insulin, add 20 to 30 milliequivalents of potassium, usually potassium chloride, to each liter of IV fluid. To each liter of IV fluid, that means 10 to 15 milliequivalents for each 500 ml of IV fluid. Okay. If the potassium level is between 3.3 to 5, then for each half liter of IV fluid, we should add 10 to 15 milliequivalents of your potassium level. Okay. Okay. And if it is less than 3.3, then we should add 40 milliequivalent. We should give 40 milliequivalents per hour of, every hour we should give 40 milliequivalents. That means you should give centrally. Okay. Now if the potassium level is more than 5 milliequivalents per liter, then don't give potassium, monitor closely, levels will fall with treatment itself. And one key point is, here it is one key point, ensure adequate urine output before starting potassium supplementation. And remember, if the patient is not having urine output, don't give potassium, because always give potassium when the urine output of the patient is good. Okay, this point should be remembered. So just to summary, less than 3.3, give potassium IV 40 milliequivalents every hour. Don't start insulin until the potassium is more than 3.3. When the potassium reaches 3. Or if the potassium is 3.3 to 5, then start insulin along with 10 to 15 milliequivalents every half liter of IV fluids. If the potassium is more than 5, don't add potassium, give insulin directly, and the raised potassium will resolve with IV fluids and insulin itself. Okay. And one more thing is, ensure that urine output is good in patients when you are adding potassium. Okay. And the third thing is insulin therapy. Important, insulin therapy. After excluding hypokalemia, start regular insulin. So if the potassium is less than 3.3, don't start insulin. So after excluding hypokalemia, start regular insulin, 0.1 units per kg per hour IV infusion. So one thing is, initial 0.1 unit per kg IV bolus is optional and often omitted. So some physicians give this 0.1 unit per kg of IV bolus, like 6 for 60 kg adult, they give for example 6 units IV bolus, then they will start insulin. So this is an optional thing. Some people will do this and some people will directly go on to the infusion. So 0.1 units per kg per hour IV infusion is the rate. Target glucose fall, every hour the glucose should be measured, every hour potassium should be measured. Remember, target glucose fall is 50 to 75 milligram per deciliter per hour. Okay, suppose this is the target glucose. Now if the glucose is not decreasing as target, okay, then double the insulin infusion rate. For example, if the glucose is falling less than 50 milligram per deciliter every hour, then you will double the insulin infusion rate. From 0.1 to 0.2 you will do 0.2. But one more thing, if the glucose is falling more than 75 milligram per deciliter every hour, then you will half the dose of IV insulin. That is, you will from 0.1 you will do it as 0.05 units per kg per hour. So that thing should be kept in mind. Okay. Now continue insulin infusion until anion gap is closed on 2 consecutive tests and blood or urinary ketones are negative. Okay, 2 tests are necessary until the anion gap is closed. This anion gap is measured by the VBG or ABG, and urinary ketones and blood ketones are negative. So these 2 conditions are met, then till that point you should continue the insulin. Glucose monitoring guide. When the glucose is more than 250 milligram per deciliter, insulin infusion plus non-dextrose IV fluids should be given. When the glucose reaches 200 to 250, meaning less than 250, then add dextrose D5 to IV fluids and continue the insulin infusion. One point to remember is, do not stop insulin until the DKA is fully resolved, even if glucose becomes normal, okay, because DKA resolves by insulin. Okay. Then coming to insulin is over, then correction of the cause is there. This is an optional thing. Fourth thing, what is that? That is bicarbonate therapy. This routine use is harmful actually. Bicarbonate therapy, it worsens the intracellular acidosis, exacerbates the hypokalemia, and is strongly associated with development of fatal cerebral edema, especially in pediatric and adolescent populations. So that's why routine use of bicarbonate is not indicated in patients with DKA. Use only if there is profound life-threatening acidemia. For example, if the patient is having pH less than 7, meaning severe DKA. How much? Give 50 to 100 milliequivalents of sodium bicarbonate over 2 hours cautiously. Okay, cautiously should be given. So if routinely given, it will worsen the acidosis, it will worsen the hypokalemia, and it can cause fatal cerebral edema. It is indicated only if the pH is less than 7, and that to 50 to 100 milliequivalents sodium bicarbonate, which should be given for 2 hours. 50 to 100 milliequivalents of sodium bicarbonate over 2 hours, it should be given very cautiously. Okay, in severe cases only, otherwise it is not needed. So first is volume, then second is potassium, third is insulin, fourth is correction of the cause. Okay, so resolution criteria: DKA is considered resolved when pH raises more than 7.3 or bicarbonate raises more than 18 millimole per liter. This is one condition, meaning acidosis is resolving. So ketoacidosis, no, acidosis is gone. Now keto thing, the keto thing. Okay. Second thing, plasma and capillary ketones level should be less than 0.6 millimole per liter. Plasma and capillary ketone level should be less than 0.6 millimole per liter, or urinary ketone level should be 0. So these two things. DKA, diabetic means hyperglycemia, keto means ketones, acidosis means acidemia. So this ketoacidosis should resolve. Serum ketone should be less than 0.6 millimole per liter, and acidosis, meaning pH, should be more than 7.3, or bicarbonate should be less than bicarbonate should be more than 18 millimole per liter. That is the resolution criteria. If the patient is able to eat, at that time, transition to subcutaneous basal bolus insulin regimen is required. Okay, when you should give basal bolus insulin? When the patient is able to eat, at that time you should give the basal bolus insulin subcutaneously, and you should give this subcutaneous insulin before stopping the IV insulin, 2 to 4 hours before stopping the IV insulin. Continue the IV insulin infusion for 2 to 4 hours after the first subcutaneous basal insulin injection is given to prevent rebound hyperglycemia and recurrent ketoacidosis. Okay, that's the thing. And one more thing, if the patient is not passing urine, then you insert urinary Foley's catheter. You should insert one thing. And if the patient is not able to take orally for a long time, then insert Rais tube and give food through that to the patient. So this is one more thing which should be kept in mind. Okay, always remember, vitals should be monitored frequently. Every hourly the vitals should be monitored. Check labs, that is glucose, potassium important, sodium important, bicarbonate important, and ketone bodies important. Okay, watch for signs of cerebral edema, very important, cerebral edema. Okay, patient may end up with cerebral edema anytime. That is headache, confusion, vomiting, decreasing GCS of the patient. Okay, identify and treat the underlying precipitating cause. For example, if the cause is infection, give antibiotics. If the cause is myocardial infarction, then give thrombolysis or percutaneous coronary intervention. So that's about the how to treat the cause. So that is about the management of diabetic ketoacidosis. So same thing in the form of a flowchart. First, what we are doing, we are assessing the patient. If the pH is less than 7.3, glucose is more than 250 milligram per deciliter, ketones are positive, then the patient is in DKA. We are giving 1 to 1.5 liter of 0.9% saline in the first hour. Then we will assess potassium. If the potassium is less than 3.3, hold insulin, give 40 milliequivalent per hour of potassium till the potassium reaches more than 3.3. If the potassium is 3.3 to 5, then add insulin. Along with that, give 20 to 30 milliequivalents potassium per liter or 10 to 15 milliequivalents per half liter of IV fluids. If the potassium is more than 5, give insulin and hold potassium. Recheck in 1 hour. After that, start insulin infusion, 0.1 units per kg per hour, continuous IV regular insulin. Blood glucose should fall 50 to 75 milligram per deciliter per hour. Now, after starting insulin, you monitor glucose, you monitor pH, you monitor bicarbonate, you monitor potassium, you monitor all these things. Okay. Glucose monitoring and insulin dose adjustment. When blood glucose falls, if glucose falls less than 250 milligram per deciliter, add 5% dextrose or 10% dextrose to IV fluids. Do not stop insulin, continue and adjust rate as per table. Adjust IV insulin dose according to fall in blood glucose level. Target range is 50 to 75. Continue the same rate. If the blood glucose is falling in between these 50 to 75, then continue the same rate. If it is less than 250 milligram per deciliter too fast, then decrease the rate by 50%. For example, 0.1 to 0.05 unit per kg per hour. If it is more than 75 per deciliter, meaning the glucose is falling more than 75 milligram per deciliter, increase the rate 0.1 to 0.2 units per kg per hour. Check blood glucose hourly. So if the blood glucose, sorry, it is actually reverse. Okay, actually it is reverse. This should be here and this should be here actually. So if it is more than 75, then you should decrease the rate. I will just have here. If it is falling more than 75, then it is too fast actually. So then decrease the rate. If it is less than 50, then you should increase the rate. It is too low. Okay, and check the glucose hourly. DKA is resolved when pH is more than 7.3, bicarbonate is more than 18, ketones is less than 0.6 millimole per liter in the blood, or urinary ketones are negative. Transition to subcutaneous insulin. Start subcutaneous basal insulin when the patient is able to take food, and continue IV insulin infusion for 2 to 4 hours after first subcutaneous basal insulin dose. Then stop IV drip. Why this thing? Because to avoid rebound hyperglycemia and diabetic ketoacidosis. Continue close monitoring of vitals, meaning BP, pulse rate, heart, respiratory rate, glucose, electrolyte, sodium, potassium, bicarbonate, pH, okay, and urine output throughout the treatment. Okay, that's the thing. Very much easy. Okay. Now, special situations and pitfalls what we do in managing. One condition already you know, euglycemic DKA. A rapidly emerging and treacherous clinical pitfall is the presentation of DKA with normal or only modestly elevated blood glucose levels less than 250 milligram per deciliter. Common precipitants are SGLT2 inhibitors, pregnancy, alcohol overuse, liver patients, cirrhosis. So these two are same, only one and same: cirrhosis and alcoholic patients, pregnant ladies, and SGLT2 inhibitors. So these four conditions we can have euglycemic diabetic ketoacidosis. So we should have a more suspicion of DKA in these type of patients. In pregnancy, in those who are using SGLT2 inhibitors. Nowadays SGLT2 inhibitors are used very widely. So even if the glucose levels is more than 200 levels, then we should suspect DKA and measure the urinary or serum ketone levels. Okay, pregnancy is also a high risk, and alcohol overuse and cirrhosis patients also. SGLT2 inhibitors lower the renal threshold for glucose, profound glucose without glucose lost in relative lack of insulin, plus SGLT2 inhibitor rising glucagon, there is massive ketogenesis. Okay, clinicians must rely on the anion gap and quantitative beta hydroxybutyrate levels rather than glucose criteria to secure the diagnosis. Okay. Management requires the immediate co-administration of IV dextrose 5 or 10% alongside the standard insulin infusion to allow ketone clearance without plunging the patient into severe hypoglycemia. I said no, the funda behind giving this 5 to 10. So that same funda is discussed. SGLT2 inhibitor effects can persist for 10 to 14 days post discontinuation, requiring extended monitoring. This is an important point. So even if a patient develops DKA due to the use of SGLT2 inhibitor, the effects of SGLT2 inhibitor persist for 10 to 14 days. So we should monitor that patient who develops DKA due to SGLT2 inhibitor use for 1 to 2 weeks. A special point. Okay, for 1 to 2 weeks you should monitor this kind of patient. So that is one thing, euglycemic diabetic ketoacidosis. Coming second thing, that is cerebral edema, a rare but catastrophic complication occurring in less than 1% of DKA presentations, predominantly affecting children, adolescents, young adults. Warning signs of this cerebral edema include headache, fluctuating levels of consciousness, bradycardia, and sudden respiratory arrest, meaning apnea. Okay, so headache, GCS level low, bradycardia, decreased heart rate, decreased GCS, headache, and apnea. So we should monitor the heart rate also. So this is CNS, this is CVS, this is respiratory. So these systems will help us to detect this cerebral edema. The exact pathophysiology is linked to rapid shifts in serum osmolality and brain ischemia. How to avoid this complication? Gradual reduction in blood glucose, target fall between 50 to 75 milligram per deciliter. So if the blood glucose is falling rapidly, there will be shift of fluid, and either the brain cells will lose the fluid or they will gain the fluid, causing cerebral edema. Okay, so gradual reduction of blood glucose is required. Avoid rapid hypotonic fluid doses, hypotonic fluid like 0.45%. These are all hypotonic fluids. Strict avoidance of bicarbonate therapy. Routine use is not indicated. Bicarbonate therapy only in cases of severe DKA. Okay, so bicarbonate therapy use is associated with increased risk of this. So very fast, if the glucose is falling, risk of cerebral edema. Hypotonic fluid boluses you are giving, risk of cerebral edema. Giving bicarbonate, risk of cerebral edema. Patients with highest blood urea nitrogen BUN levels and lowest PSO2 are at the greatest risk. So if blood urea nitrogen is raised and PSO2 is decreased, then these are also a marker of, we can say it as a laboratory marker of cerebral edema, risk severity markers of cerebral edema. Okay, so BUN and PSO2 level, venous blood gases and BUN levels. Okay, we should want bicarbonate, glucose, and hypotonic fluid solution. Early recognition of these special situations and avoidance of common pitfalls are important to preventing severe complications and improving the outcomes in diabetic ketoacidosis. Okay, now we will end this DKA topic by seeing a practical case scenario of diabetic ketoacidosis. Case scenario: 24-year-old male with known type 1 diabetes mellitus. Patient presentation: brought to the emergency department with a 2-day history of severe nausea, vomiting, abdominal pain, and increasing drowsiness. He reports missing his basal insulin for 2 days due to a fever and stomach bug. Okay, patient will think that if I take this basal insulin, then I will develop hypoglycemia and they will miss their basal insulin. Always remember, this is already discussed in the topic of diabetes mellitus. Never ever the patient with who is taking basal insulin should stop his basal insulin in any condition. Even if he is not taking oral intake, even if he is having diarrhea, vomiting, anything, he should stop his meal boluses, but he should not stop his basal insulin. This should be also here the same thing. Same thing has happened. This patient may be thinking of he is having a vomiting and diarrhea, and if I take insulin I will develop hypoglycemia, and he what he did, he missed the basal insulin for 2 days because of that thinking, and he developed DKA now. Okay, so at the point of admission his BP was 90/60, heart rate elevated 128 beats per minute, respiratory rate is increased 28 per minute, temperature is 37.8, this is also raised, meaning feverish. So this is Kussmaul's breathing. Hyperventilation, if you measure the saturation in these patients, saturation levels will be normal, but respiratory rate will be increased. So this is a clue that the increased respiratory rate may be due to acidosis. Okay, normal SpO2 and increased respiratory rate. Now, initial assessment and diagnostic. His capillary blood glucose was 480. In venous blood gases, pH was 7.12. So, meeting the right, it is less than 7.3, and but more than 7. So, it is moderate diabetic ketoacidosis. Bicarbonate of 10. Okay, bicarbonate of 10. Basic metabolic panel. So, sodium is 132. Potassium is 4.1, between 3.3 and 5. Chloride is 98. We need these two. Okay. Basic metabolic panel. VBG is also done to know the bicarbonate pH. Okay. Calculated anion gap. Sodium minus chloride plus bicarbonate. So 132 minus 98 plus 10. So 24. Very much elevated. Okay, very much elevated. Anion gap is very much elevated. Ketones, serum beta hydroxybutyrate is markedly elevated. So DKA is diagnosed. Okay, and it is moderate kind of DKA. So this can be managed in ward itself, but requires close monitoring. Okay, acidemia less than 7.3, bicarbonate low, high anion gap more than 12, 24 it is, high glucose more than 250, positive ketone bodies. Immediate action: in the first hour, we gave 1 liter of 0.9% NS over 1 hour to correct hypovolemia and improve the renal perfusion, and hold insulin briefly because potassium is 4.1, normal range, but will drop with insulin. It is safe to proceed with insulin, but potassium replacements begin simultaneously. So what we are doing, we are adding 20 to 30 milliequivalent of potassium chloride to each liter of IV fluid to prevent dangerous hypokalemia. So we have given the fluids, and now we are adding 20 to 30 milliequivalents of potassium chloride to avoid hypokalemia, and in 1 to 3 hours. So first hour we are taking care of fluid level. From 1 to 3 hour, active correction. So we have added potassium also. The fluid adjustment now. After the initial bolus, switch to 0.45% NS at 250 to 500 ml per hour, since corrected sodium is typically normal or high in these states. Okay. Insulin initiation. Start, and after 1 hour we are starting insulin. Okay. IV regular insulin infusion at 0.1 units per kg per hour. For this 70 kg patient, start at 7 units per hour. Okay. Monitoring. So monitor blood glucose every hour, monitor VBG and basic metabolic panel every 2 hours, monitor potassium and replace as needed. Okay, potassium also should be monitored every hour, glucose should be monitored every hour, pH, bicarbonate and other electrolytes, urine, creatinine should be monitored every 2 to 4 hours. Potassium and glucose should be monitored every hour. The crucial titration point, adding dextrose. Now reassessment after 4 hours. At 4 hour. Okay, so now the current blood glucose is 220, which is less than 250. VBG shows pH is 0.24, patient is improving. Bicarbonate is 14, okay, improving. Anion gap is 17, improving, but still it is open. The clinical trap: blood sugar has normalized, but the patient is still in DKA. See, the pH is still low, bicarbonate is still low, anion gap is still high. So still the patient is DKA, but sugar is normalized. Because the anion gap is still open, ketogenesis is still occurring. So do not stop insulin. What you will do? You will add dextrose. Change the IV fluid to D5 half NS at 150 to 250 ml per hour. Then titrate the insulin. Reduce the insulin infusion rate slightly to 0.02 to 0.05 units per kg per hour to maintain the current glucose between 150 to 200 milligram per deciliter. We don't want blood sugar to fall rapidly now. That's why we are reducing the insulin infusion rate to 0.02 to 0.05, meaning less than half per kg per hour. Okay. What is the rationale? The dextrose prevents hypoglycemia, allowing you to keep the insulin infusion running to shut down lipolysis and clear the ketones. At hour 10, labs CBG is 165 milligram per deciliter. VBG is pH is now more than 7.3. Bicarbonate is more than 18. Okay. Bicarbonate is more than 18. Anion gap is 10. Anion gap is now closed. So less than 12 it is. 10 meaning less than 12. Clinical status: the patient is awake, alert, nausea has resolved, and he is asking for food. So DKA is officially resolved. Now at hour 10 to 12, the transition subcutaneous overlap. Administer the subcutaneous basal. Give the patient their usual dose of subcutaneous long-acting insulin like Glargine 20 units. The overlap window. Keep the IV insulin infusion running for 2 hours after administering the subcutaneous Glargine. Meal time. Allow the patient to eat. Administer subcutaneous rapid-acting insulin, example Lispro to cover the meal. For discontinuation, exactly 2 hours after the subcutaneous basal injection, turn off the IV insulin drip. Monitoring. Check current blood glucose before meals and bedtime to ensure the subcutaneous regimen is holding the blood sugar stable. What are the key takeaways? Assess recognize DKA early with labs and clinical evaluation. Bolus fits to restore perfusion first. Check and replace potassium early. Start insulin, continuous IV insulin to stop ketogenesis. Add dextrose when glucose falls less than 250 mg and do not stop insulin. Frequent monitoring, adjust therapy based on it. So glucose and potassium every hour. Other basic metabolic panel like pH, bicarbonate and urea creatinine 2 to 4 hours. Zero rebound. Overlap subcutaneous insulin to prevent rebound diabetic ketoacidosis. So that's a case of diabetic ketoacidosis. Thank you.